everyone, and welcome to This is Growing Old, the podcast that's all about the common human experience of aging. My name is Sue Peshin, and I'm the president and CEO of the Alliance for Aging Research. May is Mental Health Awareness Month, as well as Older Americans Month, and it's an important time to talk about emotional, psychological, and social well-being as we age. Here to join us for this great conversation is Dr. Dilip Jeste, professor of psychiatry and director of the Sam and Rose Stein Institute for Research on Aging at UC San Diego. Dr. Jeste is a geriatric neuropsychiatrist who specializes in mental health and well-being with age and is one of the Alliance's favorite people to talk to. Dr. Jeste, Dilip, thank you so much for joining us today.
Thank you, Sue. It's a pleasure and a privilege being on your podcast. I've had the pleasure of knowing you and the Alliance for many years, and I have great admiration for what you do.
Well, we're right back at you. So we're excited too. So you have focused a good portion of your work on mental health and wellness across the lifespan. Why do you think this is so important?
You know, when we talk about aging, most people have a negative picture of aging. Aging means decline, degeneration, dementia, disease, and death. And that is because people look at aging primarily from physical health perspective. And physical health does decline with age, no question about that. However, that is not the main thing. The main thing is wellness and personal well-being, happiness, contentedness. And there is something I call paradox of aging. We did a study of 1,500 people from the community from age 20 to 100 plus. And we have been following them for 10 years now. And we are looking at physical health as well as mental well-being. Physical health, as we all expect, declines with age. 20s and 30s at the fountain of youth, the best physical health. By the time we reach 80s, 90s, the physical health had declined considerably. However, if you look at mental well-being, it goes exactly in the opposite direction. The fountain of youth, 20s and 30s, is also a fountain of anxiety, stress, and depression. A lot of peer pressure. You feel that you're not doing as well as others, and you're not sure what you're going to do. Compare that to people in the 70s and 80s who are much more happy, contented. They are happy with what they have done and feel lucky that they are still alive and doing well. Okay. So mental well-being really goes in the opposite direction, and that is what matters. Ultimately, the purpose of life is happiness, contentedness. And so increasingly, even in medical research, the focus has become well-being rather than strictly physical health.
Mm-hmm. Yeah, I love that. I love hearing you talk about that too. And you also speak about the wisdom of aging. And in fact, you've written a book about the wisdom of aging. What do you mean by this? And would you share some of your findings from your wisdom research and tell us a little bit about your book?
Yeah, sure. Thank you. So I was born and grew up in India, and in many Eastern cultures, older people are respected. They're thought to be wiser. And I took it for granted, but I never thought much about it until decades later when I became a geriatric psychiatrist and a neuroscientist. And I said, is this true? Can we empirically show that older people have more wisdom? The first question is, what is wisdom? The concept of wisdom has been there practically from the beginning of humanity. All the religions, philosophies mention wisdom. But empirical research on wisdom started only in the 1970s. Started in Max Planck Institute in Berlin and at University of Southern California in Los Angeles. But it has been growing since then. There were 2,000 papers on wisdom just in the last decade. So we began doing research on wisdom about 15, 20 years ago. And the first question was, How do you define wisdom? That is critical. Wisdom is a personality trait. It's a trait like resilience, optimism, introversion, extroversion. It describes a pattern of behavior in an individual. However, wisdom has several components.
Mm.
The single most important component is empathy and compassion, understanding others' emotions and helping them. Second component is emotional regulation, control over the emotions, not like a teenager whose emotions fluctuate hour to hour, minute to minute. Third is self-reflection, ability to look inwards, trying to find out what we did wrong and how can we do better. So these are the main components of wisdom. So we have been studying wisdom in an empirical way. We developed a scale for measuring wisdom called San Diego Wisdom Scale. The larger version has 28 items, shorter version has 7 items. And any of you can access that on our website and complete it. And you then get scores for each component of wisdom that I mentioned. Wisdom is biologically based to some extent. It is based in the brain, of course. And we identified specific regions of the brain that are important, like prefrontal cortex and limbic striatum.
Oh.
Wisdom increases with aging. Not in everybody. There are some old people who are very unwise, some young people who are very wise. But by and large, as we all get older, we become more empathic and compassionate. We become more controlling over our emotions, more self-reflective. So it does increase with aging. But again, as I said, not always. So we have to try. But the last part I want to mention is that there are ways in which wisdom can be increased. There are randomized controlled trials that show that we can increase empathy, compassion, emotional regulation, etc., through psychosocial and other means.
Well, this is interesting, and I want to ask you a little extra question, which we can cut out if it, you don't want this in here. But one thing I've thought about since reading your book is, there's so much going on today. There's, a lot of people who are not getting along with each other, right? And you can have compassion and empathy for a lot that's been revealed, right? About disparities in racial and ethnic communities, attitudes towards people with disabilities, the talk about rationing when we were in COVID with ventilators, all this type of stuff. But and you can be compassionate and have empathy towards it, but it can also be very upsetting emotionally. And so I'm just sort of wondering, and so in order for you to want to change things, right, that takes a bit of kind of passion and almost righteous anger. So how do you reconcile all of that?
You make a great point. So, just like there is individual wisdom, there is societal wisdom also. And what has happened to our society in the last 2 or 3 decades is that things have gotten worse. There is considerable more loneliness and social isolation today than there was 25, 30 years ago. And this is actually a pandemic, behavioral pandemic that has been going on. For example, according to CDC, the rates of suicide in the US have gone up by 33% over the last 2 decades. Rates of opioid-related deaths have increased tenfold over this period of time. And one of the main contributors is loneliness, social isolation, but also there is more anger, hostility, depression, stress. The Gallup polls show that. So there is no question that things are not going well. And we need to do something about that. And so what is needed at individual level, is also needed at societal level. We need to teach people about empathy, compassion, emotional regulation, self-reflection. We typically reward hard skills, reading, writing, arithmetic, in medical school, how to be the best diagnostician and treatment prescriber. We don't teach our medical students, or even actually starting from kindergarten, how to be compassionate toward others, how to regulate our emotions, how to be self-reflective. In sports, we recognize the champions, but we don't give sportsmanship awards. And so really what we need is more compassionate community and more understanding and accepting diversity of perspectives. That's really critically something we are lacking today.
Yeah, I like that. So it's, it's one thing to have it on an individual level and to try to work to cultivate it on an individual level, but it can be challenging when the society is going in the opposite direction. It's interesting. So you helped us tremendously with these mental health fact sheets that we worked on, and we're very excited to release them this month with the Awareness Month. And we're releasing them on these topics related to substance use disorders, Alzheimer's and related dementias, depression, and suicide. Some of these are what you talked about, the diseases of despair. And then we also included Alzheimer's and related dementias. And these are focused on tips for clinicians to talk with their patients about these complicated and often sensitive subjects. So, and again, you provided the expertise as a reviewer. And so I wanted to dig into those a little bit. So starting with the one on substance use disorders, why are older adults at increased risk? And what can clinicians say to their patients who are dealing with a substance use disorder?
Yeah. First of all, I want to compliment the Alliance for creating these fact sheets. They're really terrific and really very helpful for clinicians as well as for family members and people suffering from this condition. So substance use disorders are much more common in older people than people think. There are something like 1 million Americans, older Americans, who have substance use disorders. And they are often underdiagnosed and definitely undertreated. Because people think that older people don't abuse substances. And that's not the case. As I said, it is not uncommon. But people attribute that to something else. And the risk of substances actually increases in older age because older people have multiple physical illnesses. They are on multiple medications for different illnesses. On top of that, they take the supplements, the over-the-counter medications, and all of these interact and they produce more side effects and more harmful effects in the longer term than in younger people.
Yeah.
So one reason why it is more common here, because this is the baby boomer population getting older. And these baby boomers, when they were younger, they use substances like marijuana or cocaine to reduce the stress. And now in old age, as they again become stressed out, they go back to those substances.
Mm-hmm. Right. Yeah. And doctors are also very hesitant to ask about alcohol use. Right. And a lot of drugs interact with alcohol as well. That's very true. Well, I want to give a shout out to Lindsay Clark, who is our vice president, senior vice president for health education and advocacy, and she created those sheets. And to thank you for your assistance in reviewing them. So with Alzheimer's disease and related dementias, what are some of the behavioral changes that loved ones can expect to see in many cases, and what are some of the ways that they should communicate with their loved ones when they're going through those issues?
This is actually a very important question because Alzheimer's disease is very common. It's the most common form of dementia, and the risk of dementia increases with aging. It is often underdiagnosed and undertreated, and underdiagnosed because people often confuse any worsening of memory with aging only rather than that it might be an early sign of dementia. So this is something that should be looked for carefully. So that should be examined by clinicians in their annual wellness visit. So when interviewing a patient, see if you are seeing any signs of decline from the previous visit. Ask the patient, ask the caregivers. And if you see something, then you can use some screening tools that are available. There are some which are only 8 items scored, or there is this Montreal Cognitive Assessment scale that can be used. I think it is useful to have them to detect dementia at an early stage. Because the earlier you diagnose it, the more you can do. And we had to be direct, honest, and empathic with the patients and the caregivers. This is really important. If they have a diagnosis of Alzheimer's, they need to know that. And we also need to document it. We need to document it for the sake of other physicians who are treating other illnesses like heart disease or cancer. It is useful for them to know that the person has dementia. But it is not just a diagnosis. We need to discuss the prognosis. What is the course? And the course is highly variable. Some people can have rapid progression, others will have slow progression. And the symptoms of Alzheimer's, in addition to memory impairment, are often behavioral. Depression is common. People become agitated. Yeah. They sometimes forget that they have eaten, so they may have 2 dinners, and sometimes they may not have any dinner for 2 days. Sometimes they become paranoid. They start accusing their loved one, the caregiver, with having affairs or stealing money. It becomes very hard on the caregivers. Being caregiver of a person with Alzheimer's is very difficult. But there are support groups that are available. So the main thing is that you need to have a clear attitude that this is an illness. It needs to be cared for. There is no cure at this time, but there are ways in which the negative effects of Alzheimer's can be minimized.
Yes, absolutely. And really good, kind of communication tips and tools around it so that it kind of will help take the stigma away so people can talk about it in a more open way. So I think all of our listeners understand what a tremendous toll depression can take on an individual and their families. But many people don't realize that those who are 65 and older account for 16% of the population, but 19% of the suicides in the US. And there are a lot of contributing factors to this, but one of them is that it can be more difficult to detect depression in older adults. Can you explain why that is and what clinicians should be doing to better ensure that they're not missing diagnoses?
Again, that's a very important point. What happens is that the symptoms of depression, such as difficulty in sleeping, not enjoying life, not taking pleasure in anything that they do, not eating well. People often attribute those to normal aging or to some stress that they may have or some situation that may have occurred. But when these symptoms last for a long time, then they deserve a diagnosis of depression. And what is useful to know is that major depression is less common in older people than in younger ones, but it is the so-called subsyndromal depression that is very common. So instead of 5 symptoms, they may have 3 symptoms. But even one symptom can have negative impact. So it is really important to check for the symptoms of depression. Again, there are various assessment scales. Asking the caregivers is important because depression can affect physical health markedly. If people don't eat well, if they don't sleep well, clearly that is going to have an impact on their health. Some of the illnesses they may have, like diabetes, arthritis, cancer, whatever, the treatment of those conditions becomes worse with depression because then you don't take any treatment. So it is important for others to know that somebody has depression, and at the same time not feel guilty about it. It is not because they have done something wrong. It is a disease, but it can be treated. I think depression is very treatable. There is no single effective treatment. Antidepressants are there, but they take several weeks before they start acting. Psychotherapy is critical.
Yeah.
And it can be supportive therapy, it can be cognitive behavior therapy, family therapy, group therapy, whatever it is. But it does play an important role. And some of the depression is preventable. For example, in older people, if you have heart attack, myocardial infarction, or a stroke, you're much more likely to have depression.
Yeah.
So you can start looking at a person who just had a stroke or myocardial infarction. You can expect that that person has a higher risk of depression. So you start working with him and the caregiver to detect depression and to prevent it at that stage. So there is a lot that we can do with depression in older people. And as you said, the risk of suicide being higher is really something to keep in mind. At one time, I remember as a physician, we were told that don't ask about suicide. It'll make the person suicidal.
Yeah.
That is exact opposite of the truth, where if you ask a person about suicidal thought, they will actually admit that, yes, they have been having suicidal thought. And if you don't ask them, they won't tell you that. So it is critical that we ask about that, ask about past history of suicidal attempts, family history, if they have some weapons in the house, if they are living in a safe environment. All of these questions are critical for preventing suicides in older people.
Right. Yeah. And I'm so glad you mentioned that, like asking someone if they have had thoughts about hurting themselves is not going to cause them to have those thoughts. But it's a very real question, and you generally will get a direct answer back, and it can save someone's life if you find that out. So I know we've just scratched the surface on a lot of great content and expertise shared in these tip sheets. So I just invite everybody to please check them out in the mental health section of our website at www.agingresearch.org. Before we turn to our more lighthearted question that we ask all of our guests, I just want to ask you one more question about your work that ends on a positive note, which is positive psychiatry. Tell us, what is positive psychiatry, and what's one thing we can all do to work on positively improving our mental health?
And that's a great question, an important one. When I was the APA president in 2012-13, one of my jobs was to get the DSM-5 published. And that was important. But DSM-5 is kind of an encyclopedia of psychiatric diagnosis. But is that all that we do? Psychiatry is defined as a branch of medicine for treating mental illnesses. And I think that is not right. We are as psychiatrists, and that applies to psychologists, social workers, nurses, all of them. We as professionals are not restricted to only treating mental illnesses. Our job is to improve mental health. 20% people have mental illnesses, 100% people have mental health. And we need to think about something positive. Our job is not merely to reduce the severity of depression or dementia. Our job is to make people happier. And that is something, so we need to, as clinicians, we need to ask the patient what they like about themselves. What are their strengths? Because those are the things that are helpful in improving their happiness and functioning. And that is positive psychiatry, where we think about not just risk factors, but protective factors. We think about resilience, optimism, wisdom, compassion. Those should be as important as any illnesses that we treat.
Absolutely. I love that. And connection, right? It's so important to feel purposeful and connected as we get older. So now to our closing questions. Our first one that we ask everybody is, when you were a kid, what did you imagine growing older would be like?
Actually, I had read a book called Lost Horizon, and written by James Hilton. And it's a story of people in Tibet in the Himalayas, and they lived to the age 200 plus. And they were all very busy, older people, active, etc. And for a long time, I thought that was a real story based on fact. When I found out it was fiction, was very disappointed. But that was the idea of the old age, that you not only live long, but you live healthy life, and you are active, and you contribute to functioning of yourself as well as other people.
And so what do you enjoy most about growing older now?
What I enjoy most is actually still learning. I mean, I call myself a professional student. And that's the fun part. There is always something new to learn. And one should never stop learning. Again, we learn different things at different ages and different stages. And of course, we can learn things that are impossible for us to learn. I mean, I cannot be an engineer tomorrow or computer scientist, but within the research I do, I can do something differently. So, and that should not go away, irrespective of age.
Yeah, curiosity, all of that. That's terrific. And also, I'm assuming you still have your ID, right? That was always a big deal, your student ID in school.
Yes. Right.
So thank you, Dilip, so much for joining us. It's always great to see you. And I want to tell everyone for listening, thank you so much for listening to This is Growing Old. If you're enjoying the show, please subscribe wherever you get your podcasts, and hope everybody has a wonderful day. Take care.